We'll give everybody just a minute here to log in. Well, good morning, everyone. Welcome to Mayo Clinic Neurosurgery Neuroscience virtual grand rounds. Every week we try to host a thought leader in our field, both senior, again, thought leaders or rising stars. And this week we have a very special guest, Dr. Joshua Bakhsheshian, who's going to be introduced by some of our scholars and students. So please, team, go ahead.
Good morning, everyone. Today we have the honor of introducing you to Dr. Joshua Bakhsheshian. Dr. Bakhsheshian is currently an assistant attending physician at the Department of Orthopedic Surgery at New York Presbyterian Hospital, where he's also completing a postgraduate fellowship in adult and pediatric complex spine deformity. He received his medical degree with a distinction in research from Chicago Medical School and completed his neurosurgery residency at the University of Southern California. Dr. Bakhsheshian has been awarded numerous distinctions throughout his career, including the Fellows Award for Research Excellence from the National Institute of Health, the Physicians of Tomorrow Award from the American Medical Association, among other decorations from prestigious organizations.
Dr. Bakhsheshian has also given countless presentations on psychosocial and technical aspects of spine surgery, as well as other topics at both a national and international level. He's published extensively within the fields of neurosurgery, combining clinical interests with research in clinical outcomes, as well as development of surgical techniques to advance safer, evidence-based spine care. He also completed a number of NIH-funded research projects on subjects such as developing models to investigate the function of the blood-spinal barrier and investigating physical activity monitoring during surgery, just to name a few. Thank you so much to Dr. Bakhsheshian for joining us this morning for the Mayo Clinic Neurosurgery Neuroscience Grand Rounds.
Welcome, Josh.
Thank you.
Looks good.
Thank you. All right. Thank you, everyone, for the introduction, the opportunity, and for your valuable time. We'll talk about some recent advancements in surgical planning for spine surgery. No conflicts of interest. So this topic is of great interest in the current direction of spine care, as predictive analytic techniques are already being utilized to deliver personalized healthcare throughout the industry. So there's no surprise, there's a lot of excitement with Mayo Clinic's investment in AI with recent faculty recruits, alliances, and job postings for more data scientists to integrate a number of these machine learning algorithms or AI at Mayo Clinic. This methodology can be especially useful for personalized surgical planning and delivery of spine care in the more complicated deformity cases. Why is this important? Because these patients are likely to be seen in all spine surgeons' practice. The prevalence of these deformity patients is already high, and the incidence is on the rise, especially with improved medical care, increasing life expectancy, and increasing elderly population that is healthy. Most are familiar with the cone of economy concept that was popularized by Dubois. Patients attempt to maintain a neutral, upright posture with a horizontal gaze with minimal muscle energy expenditure. So if balance is maintained within a small cone, minimal muscle expenditure is required. Pathologic disruptions of this balance can occur secondary to just degeneration as part of the aging process. When this occurs, compensatory mechanisms would decrease lumbar lordosis, decrease thoracic kyphosis, increase pelvic retroversion, knee flexion, head and neck extension can occur. But these mechanisms can fail or max out, resulting in pretty significant disability. When this is clinically significant, surgical treatment is offered to restore the cranium back to the true center of gravity or neutral alignment, as seen here in this example. To date, surgical treatment in spinal deformity patients continues to be beneficial, as a recent meta-analysis also continued to conclude. But outcomes continue to be associated with high complication rates that vary between study to study with variable results. This is likely secondary to them including a heterogeneous population with variable treatment approaches. Here we can see two different deformities. One's a primary degenerative sagittal malalignment versus another an iatrogenic with a prior Harrington rod fusion that was placed earlier in childhood, each with different thresholds in a relative structural deformity to disability ratio. So a more structured approach is needed for surgical decision making. Therefore, this talk will focus kind of on the following objectives. Popularized spinal pelvic parameters provide merely a guide for treatment and are evolving towards a more personalized approach. Computer software with advanced analytics can be used to simulate optimal correction, create implants that can help accurate execution of the plan in the operating room. This facilitates the delivery of a more personalized spine care. So starting with the first objective, we already know substantial evidence supports a correlation between sagittal alignment and patient-reported outcomes. The landmark study by Glassman kind of started us off, demonstrating that the horizontal distance of the posterior corner of your sacrum to your C7 plumb line had a linear relationship with worse health outcome scores. At that time, this resulted in a paradigm shift in assessment by using radiographs and patient-reported outcome measures and treatment with surgical goal of maintenance or restoration of sagittal quote-unquote balance. Additional studies built on this concept showed that analysis of sagittal plane must integrate pelvic parameters, so not just the C7 plumb line. On the right, same patient exhibiting three different relationships of their C7 SVA. So when also evaluating pelvic parameters, pelvic incidence is morphologic, roughly the same in the patient, doesn't change. Pelvic tilt is a compensatory mechanism. So evaluating these in this patient, we now see the same deformity with different degrees of compensation as measured by pelvic tilt, which is increasing towards the right. So basically C7 or SVA alone underestimates the severity of the deformity. When including these parameters, a stronger correlation with patient-reported outcomes is observed. So in subsequent studies, target goals known by most as the SRS-Schwab classification system were established. And what the authors did is they selected severe disability defined by an ODI, a questionnaire greater than 40 as a threshold. Linear regression models were then used to establish radiographical spinal pelvic parameters that were predictive of this ODI score. And they found the following parameters. It correlated with patient disability and therefore it provided a guide for patient evaluation and treatment. However, the parameters, as we know now, vary quite a bit based on age. So age-specific threshold and goals were subsequently identified. This study determined that on average, older patients had higher baseline disability and more likely to have some sagittal malalignment at baseline. So therefore, elderly patients don't need to be held as rigorous alignment objectives versus younger patients. But younger patients still required to meet their objective age-specific targets and might require more work. Based on these guidelines, it was noted that overcorrection was associated with an increased risk for proximal junctional kyphosis or failure without any added benefit in their outcomes. Overcorrection probably placed their body in an unsustainable alignment, resulting in unfavorable reciprocal changes in the thoracic, pelvis, and global alignment. Similarly, undercorrection was also associated with worse outcome scores. Now, while these have been accepted as targets for appropriate alignments, addressing these targets does not always prevent high mechanical complication or revision rates. There are other methods that can complement these guidelines. For example, SRS-Schwab classification that we just reviewed was based on those with reasonable spine contour. This patient with thoracic hyperkyphosis underwent a corrective procedure with their sagittal alignment somewhat maintained. However, you can see just overall, the morphology of the curve was changing the patient's thoracic curve apex, which likely led to his subluxation on 6 months follow-up. So a more personalized evaluation of this case would be analyzing the inflection points or the curvature respective to the overall spinal morphology. Rusuli classification scheme highlighted the spinal morphology types based on these individualized proportional parameters that quantify the thoracic kyphosis and lumbar lordosis more closely. These shapes correlated with the type of degenerative changes that were associated with it and the compensatory limitations each subset can have. So focusing just on the lordotic curvature, they can be grouped by high and low PI essentially. And what you can see is low PI, the apex of the lumbar lordosis is lower, higher PI, the apex of their lordosis curve is a little bit higher. And you can also evaluate the magnitude of difference to one's ideal lumbar lordosis, giving you a relative number. At the same time, you can start evaluating the degree of lordosis at each segment to give you an overall magnitude of how much there is at the lower arc versus the more proximal portion of the lumbar lordosis. And what this starts providing you is essentially PI based or specific based to that patient's more spinal morphology parameters versus prior approaches that were more linear and were correlated on a variety of patients. So what the study group did is they went ahead and they wanted to see, this was essentially designed to be able to predict mechanical complications because the prior parameters weren't as accurate in doing so. And they found that utilizing this approach in comparison to PILL, even if the patient was matched, utilizing this approach, you can fine tune which patient cohort were at higher risk for complications. And this, inadvertently or indirectly also correlated with outcome scores, just because if there's, less complications, probably better outcomes. Relative to the PIL mismatch, this had almost a 22-fold greater odds ratio in its predictive capability versus prior classification schemes. So a score based on these parameters was created to better predict mechanical complications within the same surgical cohort known as the GAP score. It also included pelvic proportion, global alignment, and age as a factor. Collectively, this fine-tuned the cone of economy concept by Duboisier that we kind of introduced earlier on. It also embedded a weighted scoring system just to make it easier to be used clinically. And based on these factors, patients were categorized as proportioned, moderately disproportioned, or severely disproportioned. And what the authors found was that complication rates were highly predicted by this scoring system. And the area under curve, which is a method for understanding really predictive performance, was 0.92, which is considered excellent. This score was applied to other data sets just to test its external validity. And they also saw that there was an increased association in mechanical complications in their database. Not only that, it also increased in its association as the years of follow-up increased in that patient cohort. But that could also be skewed because patients return long-term, mainly if there are complications. Regardless, using this score in treatment goals may decrease the rate of mechanical complications. And given that it also has an indirect impact on outcome scores, this use concurrently with other guidelines was found to actually be more predictive of what outcome scores could be at 2 years, or how or the minimally clinically important difference patients can receive at 2 years. So essentially, if they met criteria for this classification scheme and the prior one, they were more likely to meet that requirement, that improvement. So consideration of both systems offer some utility in establishing optimal realignment goals. Now that we set the bar even higher, how are we doing in reaching any of these alignment parameters? 2 separate critical reviews of surgical case series from the ISSG showed the low percentage of patients actually achieve appropriate alignment thresholds after surgery. The high rate of persistent deformity highlights a gap between clinical research and practice. And it's not just the multi-level thoracolumbar cases. This is also seen in 1 to 2 level lumbar fusions. 28% had malalignment and post-op follow-up. And this is concerning because 30% of patients exhibited malalignment to begin with. So 7% of these patients with an aligned spine had an iatrogenic worsening of their alignment. So there are difficulties in obtaining targeted alignment. And why is this? Are we not paying attention to these parameters? There are challenges just associated with predicting alignment. In the following case study, the surgeons were presented with preoperative radiographic measurements and surgical strategies seen here, and spine surgeons were unable to predict the adequacy of the plan in about a third of the cases. And the accuracy of them predicting sagittal alignment parameters was even lower. So this highlights the challenging nature of determining the amount of correction that could be achieved based on a surgical plan. Together, these studies suggest that the high incidence of persistent alignment failure may be the result of inadequate ability for planning and or possible execution. Again, this is challenging because we have to incorporate a number of factors. There are compensatory mechanisms that are more apparent also in uninstrumented flexible regions of the spine. There are mathematical models that can facilitate the compensatory to predict the compensatory changes or expected changes with osteotomies, but it can get very complicated and impractical for routine clinical use. It brings us to our second objective. Computer software with predictive modeling can be used to help us potentially plan for these optimal corrections. What is AI? It's essentially intelligence that mimics human cognitive functions, learning, reasoning, analyzing, decision-making. It incorporates algorithms that can be applied through AI in order to learn based on large volumes of data. And these insights that it provides can then be applied through actionable insights. Might be intimidating, but these are used frequently. Face ID to unlock our iPhones, Amazon recommendations, Google Maps for traffic patterns, and our social media feed. There's been an increasing interest in evaluating its use in spine surgery. Early models have already been shown to predict postoperative outcomes, including proximal junctional failure, kyphosis, pseudo failure, fusion, and outcome scores at 2 years following surgery with pretty good accuracy. Flowchart on the right, just kind of gestalt demonstrating the general process and the training, validating, and testing of select models. And the final performance is again evaluated by % accuracy and the area under the curve generally. Now, this is in comparison to studies using statistical models. We can see how these are easier to understand. They're more simple, but they lack the predictive performance. Here, we review the use of a frailty index as a better predictor of surgical outcomes versus chronological age or other comorbidity indices. The concept is relatively novel. It evaluates multiple domains shown here on the right and collectively represents a decrease in an individual's physiological reserve to handle surgery stress. So deficiencies in any of these domains have been shown to be a better predictor of perioperative outcomes than just age alone. So first, we use regression models just to determine its association. So it gives us odd ratios. It helps us quantify and stratify associations. This can now be plugged into a supervised predictive model to see if it can prognosticate these outcome parameters. Now, utilizing this approach, there are limitations because it's only as good as the data they are trained on, and we also have to test its external validation. Fast forward to the most current advanced applications of artificial intelligence in deformity surgery. Note how we evaluate data and how software can potentially evaluate the data. We rely on hypothesis-generated studies to help us with the selection of these variables. This limits inclusion of variables that we might miss due to bias and introduces confounders and other relationships versus a software machine learning techniques such as shown here, hierarchical clustering can be performed with unsupervised learning. What that means is it allows the model to just freely investigate the data for patterns that may intrinsically exist. Here was utilized to identify groups of patients based on these input features. They identified 3 patient cohorts, sorry, in 4 surgical cohorts. Together, this allowed the authors to generate an efficiency grid that can help conduct a risk-benefit analysis. This table is a summary of the average 2-year patient-reported outcome measurements and complication rates across each of these subgroups. So it allows us to kind of compare the risk-benefit of surgical interventions and approaches. Specifically, let's say we want to look at elderly patient undergoing a revision surgery that included a 3-column osteotomy. They face a higher risk of complication relative to other approaches that would include utilizing more inner bodies for correction, for support, that would result in less complication risk and a better outcome score. So it's really a proof of concept of how machine learning algorithms can provide a more personalized, specific risk-benefit analysis in a proposed treatment plan. Other algorithms can help actually group the sagittal plane deformity based on radiographic images. The specific methodology is called neural network-based algorithm, utilizing these self-organizing maps. It was previously used and shown in the literature to reproduce Lenke's adolescent scoliosis classification system, which has been vetted over many, many years. During training, Lenke shared his experience in developing this classification and how he spent countless of hours, days, months, spreading out all the hard copies of the films on the floor, measuring the angles by hand until he started to see a pattern and associated a treatment for them. However, this is too difficult and time-consuming for most to accomplish, and now can be facilitated or performed with AI assistance. Utilizing these neural network-based algorithms based on the radiographs, a study group was able to cluster, again, the sagittal morphology into distinct deformity patterns. And what we're starting to see is it's very similar to the types that Rusuli kind of classified. Each of these groups had distinct surgical characteristics, patient-reported outcomes, and inherent risks for complications. What they noticed is specifically that patients in the B and F cluster were the ones that were more likely to experience proximal junctional failure. These patients visibly had more of a positive sagittal balance than those who did not. And again, this just serves as a proof of concept for future work using computer vision in being able to classify these patients to a more granular kind of category. But how do we incorporate all of this into our surgical planning? There are free open source programs already out there that integrate a lot of the spine-related measurements and planning tools that can be implemented that utilizes vetted information from the published literature. This can be used to measure the parameters, plan operative strategies, with changes seen on a preoperative x-ray that kind of mimics the surgical maneuvers. So graphically, it can show us if our plan is sufficient. Here to the right, we can see that the plan is undercorrected. Additional lumbar lordosis at the distal segments can restore the spinal morphology back to what the presumed alignment is. So it helps us evaluate if we should increase the number of osteotomies or degree or carpentry. Additional principles can also be implemented in this software. So you could incorporate how much of a resection for a posterior column osteotomy and how this would impact the overall global alignment versus the pelvic tilt or the compensatory mechanism. Here is just shown if you take an equal cut through this vertebral body, the impact that it would have, versus if you take more or greater resection in the lower part of the vertebral body, the impact that it would have mainly on the pelvic retroversion, or if you take more of the top of the vertebral body. The granularity of this data can also be increased furthermore down to the degree by evaluating how much correction it has on the overall global alignment down to the degree of change in the lumbar lordosis. And it can tell, you can start estimating how with values. So to evaluate if an algorithm can actually incorporate all of these along with compensatory mechanisms in an uninstrumented spine to see the reaction appear, this was tested. So we analyzed a consecutive series of lower thoracic to sacral pelvis fixation and wanted to test it, how accurate the prediction could be in postoperative thoracic kyphosis prediction and pelvic compensatory mechanisms. Example case below, surgical planning is completed, executed, and then we kind of evaluate the postoperative thoracic kyphosis and pelvic tilt, and we found out that the prediction was within a pretty accurate range with minimal error. These findings were also observed by other independent studies. For this to work, we need accurate execution of our plan to minimize as many variables as we can. What I mean by that, it will bring us to our third objective, is that we plan something so potentially we can have something that can help us kind of confirm that we obtained our objective in the operating room. So in general, a number of factors are taken into consideration in the operating room. For simplicity, radiographs are analyzed throughout. Pre-op, we get standing supine films. It gives you an idea of the flexibility in the non-fused segments of the spine. Intra-op, positioning has an impact. You can increase the lumbar lordosis quite a bit or decrease it if it's not positioned correctly. After carpentry is completed with instrumentation, another radiograph is generally taken in a larger cases to evaluate alignment at that level to see if our goals are met. And if further corrective procedures are needed, or if it's ready to place a rod to contour and fix the spine. Dr. Lanke, given his breadth of experience, he's able to see when his goal is met just by looking at the spine. But this may not be the case for everyone with less experience. So perhaps others who are just learning, like such as myself, could benefit from something to be able to confirm intra-op. A study evaluating accuracy of just spine surgeons bending a rod to targeted goals found that we couldn't necessarily bend it to what we needed. We were off by about 19 degrees. As you can see here in our prior example, 16 degrees was just result in malalignments. So maybe having some kind of template would help avoid this. An example of applying this template in a complicated case shown here, gentlemen with Marfan's with progressive double major kyphoscoliosis with sagittal malalignment. The plan is to undergo multiple posterior column releases to loosen up the spine, and an L1 3-column or L1 asymmetric 3-column osteotomy, which is at the apex of the kyphoscoliosis with interbody fusions at the lumbosacral region. Given his Marfan syndrome and his anatomy, CT was thoroughly evaluated, as all patients should be, and found to have multiple type D pedicles, which are absent pedicle channels for screw placement in the lumbar spine region. So a 3D custom model was utilized to kind of further rehearse for the operation essentially, and to anticipate any anatomical hurdles before going to the operating room. At the computer, preoperative planning can be completed by entering our plan, visualizing potential compensatory changes, which here not as applicable since we are going up to the thoracic spine. It's mainly the potential pelvic tilt compensatory changes. And we also incorporate average correction achieved with each procedure and osteotomy based on the history of the surgeons involved. Realignment is simulated with this planning software. The spine contour can be visualized. A rod can be created essentially based off of the plan that's developed. And essentially after corrective procedures and the surgery done in the usual fashion, we are able to show that we're able to get the goal that we are trying to get. Demonstrating correction of malalignment in both planes. So what is the data on the durability of this? At 2 years, follow-up still maintains regional and global alignment within clinically significant limits. Accuracy in predicting the long-term alignment also improved, probably gave time for compensatory mechanisms. In general, the literature on this is very sparse. It's limited to case series, but overall, most state that it improves their likelihood of restoring plan alignment. Predictability was limited in a lot of the models discussed and published out there, but it's probably because it can only be as good as the data that it was trained on. A recent randomized control trial was actually completed on this and may provide further information when they publish their results. So in summary, intraoperative confirmation of sagittal alignment after planning can be augmented with the use of the software and rod templates. It could decrease OR time. Supposedly, it should also help with increasing mechanical resistance of the rod because there is an absence of notching, which is something that occurs from just bending the rods. Sometimes here, pictured here on the right, just to be able to get the steep lordosis or curvature that you need in a lower lumbar region, non-traditional methods have to be utilized to get that bend into the rod because the amount of curvature is already maximized using just like a typical French bender. Versus if you get this pre-contoured, that steep kind of bend is already in there. You don't have to place the rod at risk for potential fracture with increased notches. This approach can be further refined to improve its performance with additional data points. And what most exciting about this is that the improved surgical treatment plans that can come from this and the research potential. So it gives you a constant feedback loop to continuously reevaluate and improve. The goal is that this would hopefully decrease complications because they remain very high with these corrective procedures. Prevention is key. In this example here to the right, this poor patient, within a year had to undergo revision, multiple re-revisions, because once you start one complication, it can contribute to the next and a series of reoperations and additional complications. So there is a need for basically better planning, rods that might have better fatigue performance, decreasing the chance for fracture. And that may potentially also decrease the chance for pseudoarthrosis. And that might indirectly also decrease the chance for potential reoperation. Not only that, planning and templating the contour of the top of the rod can also give it essentially a softer landing, which is more harmonious with the spinal morphology. And that essentially would potentially decrease, again, the risk of kyphosis at the top segment that can also result in mechanical complications. So this would obviously have significant economic potential, given that spine-related care is already a significant contributor to the annual healthcare expenditure. But we do need more data evaluating the clinical cost effectiveness of this intervention. And the literature is sparse on this. Other benefits worthwhile to mention, given the talk on surgical planning and execution, that really deserves its own talk, is currently robotic planning is performed completely independently. And with robotic planning, you can plan optimal screw placements and place them in record time. So future integration of the softwares can make this a powerful tool in our armamentarium. Planning can obviously be improved by including additional patient factors and radiographic parameters. Till now, most of the data points have comprised of patients recruited in the US. Ethnic variations and baseline parameters are being reported and already observed. and they are not incorporated in a lot of the models that are available currently. It is not accurate at all for any C-spine alignments. It's very challenging to use in osteoporotic spines or severe deformities and might need a workaround. And again, it's pending a cost-benefit analysis. There's a lot of future research potential with these data points. So collectively, this can help with the delivery of a more personalized spine care, utilizing essentially a more intelligent healthcare model. And what this is how we approach this multidisciplinary approach discussed during indication conference. Preoperatively, the planning modeling will help predict post-operative outcomes for that patient based on our independent profiles. Really tailor treatment plans for individual patients' needs and goals. Perioperative training, surgeons can train on the simulations, augmented and virtual reality are also being utilized. Again, intra-op, we can integration of a lot of the advanced analytics from that can result in more customized implants or again with robotics, navigation. EMR, additional data extraction points for outcomes, which would again enhance our perioperative decision making. You guys are already implementing this in your own registry database, which would make it again more accurate based on its applicability in the environment that it's being the data is being acquired, so it can be internally more likely to be validated essentially. And another exciting part is remote monitoring is also starting to take more of a presence in a spine field. This provides essentially additional real-time data points. So as the patient progresses kind of through this model of care, the next patient can benefit from the additional data points to continuously improve this potential model. A lot of studies are now theorizing that the future of spine care is really shifting more towards software development, not so much hardware. These remote patient monitoring things are very advantageous because all these studies are based on surveys. They're self-reported outcomes and they're limited and they have their own subjectivity associated with that. So there are already technologies that have been available to track patients after spine surgery to monitor their rehab process. It allows the patients and physicians to kind of access this data on a wearable device. And prelim analysis already shows that some patients are not as active postoperatively as they say they would be. And some patients are a lot more active. So this additional information really can help fine-tune which patients really would benefit from improving their physical activity postoperatively. This was just a pilot study confirming the feasibility of utilizing wireless devices to objectively quantify this physical activity after spine surgery. So in summary, sagittal spinal pelvic parameters provide a guide for treatment. It really should include physiologic corrections that are harmonious with specific spinal morphologies. It requires a more thorough understanding of the nature of the patient's deformity and associated compensatory mechanisms. There are computer-assisted methods that permit the use of machine learning algorithms that continue to improve with time and with additional data points. Advances in technology with these softwares, predictive modeling, and patient-specific implants can be used to plan, execute corrective surgeries in the more complicated cases. This can also and should probably be implemented in single and 1 to 2 level degenerative cases, as again, prevention is key to prevent the patient from getting developing associated complications down the line from PJK and reoperations. And that's a roller coaster overview of a lot of information. So thank you for your time. I'm happy to answer more specific questions.
Dr. Bakhsheshian, thank you for that great lecture and really inspiring. And I'd like to invite some of my spine focused colleagues, Dr. Patel, Dr. Kalani, McClendon, Krishna, whoever's on the call, and our learners, our residents and fellows to participate in this Q&A. And but maybe I'll kick it off with a question just to get things warmed up. One of the barriers to artificial intelligence and machine learning is who's going to gather all the data. And theoretically, if we had access to dozens of data gathering folks, we could do something really great. But it's always, what do you see the future of that? Is it going to become more automated and less dependent on human effort to gather data?
To gather the data, hopefully automated, just to make it easier. I think where clinicians are already strapped, or really hospital support staff is already strapped short in terms of being able to spend that additional resource. Your hospital system already has a head start in having its own registry and is already collecting a lot of these outcome measures. And that's a huge step forward, because a lot of other smaller community hospitals are at a disadvantage because they might fall subject to having to potentially purchase these data points from like another hospital, because these algorithms are only, again, as good as what data it's trained on. And we can develop them specifically based on the data points at for example, on Mayo Clinic, and apply them within that hospital setting, which might be more accurate just because you're controlling for more variability, and it would be beneficial for those patients. Unfortunately, it might not be applicable from an external standpoint. That's where the problem arises.
A good point. Okay, Dr. Patel.
Yeah, Dr. Bakhsheshian, thank you very much for that most insightful and interesting talk. You mentioned that there's a little bit of a disconnect between having goals of correction and actually achieving those goals interoperatively when you're bending rods on the spot. And you mentioned how customized patient-specific rods can help with that. What do you see as barriers to universal adoption of that type of technology? What could we do better to get that to be part and parcel with our deformity corrections at a long segment?
To make it more universally available would be a cost perspective. If there's access to just the data planning, there are more and more centers that are investing in like 3D printing, and we don't necessarily have to have the actual rod, because the data is not out there yet in terms of it preventing fractures just from it being prevent, but just to be able to essentially have some kind of visualized template just to show that you met your correction. That's all it is. And that can be potentially, and I can say this because again, I have no conflicts of interest or financial disclosures, that would be a lot cheaper and can potentially make it more widely available.
How many centers, as a follow-up question, how many centers do you think are actually using these as patient-specific rods? Is it a very small percentage, or has it grown tremendously over just this past year or two? Where are we on that curve?
Okay, that's a very good question. So I have to kind of give you a preview of more of my background. It's a lot more evidence-based research. So preparing this kind of presentation, getting all the data for it was very difficult because there weren't a lot of publications on this, and there are not a lot of centers publishing their experience with this. I would say that I know off the top of my head about 3 centers that are consistently utilizing this resource, and that obviously introduces a lot of bias in the potential outcomes of these studies. So again, I want the focus more to be on the planning perspective, because I think those simulations, they're already out there, they're free, and they're being underutilized. And I think that in itself would lead a huge step forward in terms of preventing potential sagittal malalignment, which would lead to more complications down the line.
Thank you.
Other questions from our other faculty, Dr. McClendon, other spine faculty, residents, fellows?
Dr. Bakhsheshian, thank you so much for that great presentation and very pertinent information. I have probably a naive question. The calculations and measurements and everything. How do you see for pediatric deformity, like how rigid it is to kind of maintain those alignments, just factoring in the growth curve over time for pediatric patient as compared to adult degenerative deformities?
Yeah, so none of this would be applicable for anyone with any residual growth potential. I think that would be a lot more difficult to predict. I mean, we're still paying back for all those Harrington rods that a lot of us have placed earlier on that resulted in a lot of the fixed deformities as adults. There are a lot of innovations being done for like growing rods, and even they have issues currently with premature fusion early on. So it's not applicable, unfortunately. It's more complicated and a different approach, and would be needed in incorporation of a lot of other factors.
Thank you, Dr. Bakhsheshian, for a very insightful lecture. I had a question just in your thoughts on the incorporation of robotics and how we can utilize that a little bit stronger as we get into the next century here. Your thoughts on how we can implement that in practice?
Yeah, thank you for asking that. I can say based on my experience so far, and comparing it to where I did my residency training, which it was very difficult for them to incorporate robotic spine surgery because they were very selective in the cases that they wanted to utilize it in. Versus in my fellowship, there's one surgeon that I think you're also aware of who uses it for every single surgery, whether it's a single level T-lift or it's a T2 to pelvis spinal deformity construct. And the fact that he uses it for every single case allowed him to streamline it to a point where there is no downtime in its setup and its use. And he's become a lot more efficient. Staff has become a lot more efficient and competent in the workflow. And it has significantly, I would say, improved his OR efficiency and probably patient outcomes, because the robotic use with the technology and the segmentation can really can be more accurate than the use of navigation.
Sorry, I got a follow-up corollary question to that. Can you speak to the fact that obviously there's a safety mechanism when you actually have a feel and cannulation of cancellous bone versus you're relying on your preoperative planning and obviously intuition and your trust within the robot to make sure that you're not going to cause any neurologic harm or injury? Can you speak to validation to make sure, because you're obviously losing the tactile feel of safety? Obviously, you assume that the robot's going to be safe, but I would never want to assume on my own family. So can you talk to the validation for me?
Yeah, absolutely. Again, I'm happy to give a whole nother talk on just the use and implementation of this, but you asked a very good question, and I should have said this. Everything is done open, or it's mini open. It's not through a cannula anymore. It's not percutaneous, just to basically minimize that risk. That is a real risk. There is a skive potential. Doing these cases, even a single level, what I mean skive is if the robot drill accidentally off of the facet goes to the side, and then your screw trajectory can be off by a significant amount, even though it thinks it's in the correct position. But having a mini open kind of approach, even for a single level TLIF, it's not that much more different than some of the minimally invasive approaches with the cannulas bilaterally. You're still able to keep the incision very small. You can actually plan the screw trajectory, how lateral or how medial in terms of where you want the starting point to be, so you don't have to have such a wide or large incision. The robot planning will give you that amount of precision to be able to implement that. And the fact that it's open, you're able to confirm visually that you're in a correct spot. And this again gives credence to our training. You should never forget just the basic principles of anatomy, because even if you have all these tools, they'll continuously change. And at the end of the day, you still need to know the basics to be able to utilize these just to make you better, not to rely on them necessarily.
Great, thank you very much.
Other questions?
Well, I can do another follow-up, Dr. Bindock. You
Yeah,
showed the 30-year-old with the Marfan's with a kyphoscoliosis and deformity. I can tell you that, in practice, you and I may do it a little bit differently than Dr. Linke did, with the 4-rod construct and pretty significant sacropelvic fixation and fusion with kickstands, rods, things of that nature. With the strength of our instrumentation, and particularly in the Marfan's patient who has some flexibility, you always wonder if a 3-column osteotomy is needed. So, though you always trust your mentors and things of that nature, a little bit about, if you were in practice, would you do that case the exact same? Can you speak to a little bit about some of the nuances that you learned incorporating things from residency and also your fellowship? It's a little bit challenging because you don't have a Keith Bridwell to kind of swing the pendulum back the other way and talk to you a little bit about that. Did the patient really need this particular type of operation? Can you speak to a little bit about marrying some of the nuances that you learned over the years of treating patients with those sort of deformities?
Yeah, it goes back to kind of what you were saying the other day too. It's what works best in your hands or what would be best for the patient, also with what you're most comfortable and what you can do best for that patient. In terms of incorporating all my experience from training and what I've learned with this fellowship so far, as great as a posterior only approach to a lot of these deformities are, I do plan to incorporate a lot of the anterolateral approaches or less invasive, quote unquote, to help augment some of these longer constructs. And hopefully in hopes of decreasing the morbidity from the single long complicated approach done kind of in a single stage fashion as we did in that case. The other change is there is a lot more use of inner bodies that allow you to obtain the correction without having to do those 3-column osteotomies. That specific case needed to have a 3-column osteotomy. It was asymmetric. It was at L1. It was because it was fixed, and but it was, even in that case, if I go back to it, I'll show you that we did. Dr. Linke is shifting more towards placing titanium interbody grafts because there is a much higher rate of mechanical failure when you just rely on cancellous bone to remain there and heal when you go through all 3 columns, obviously.
Dr. Bendock, I was just going to mention, dovetailing on that, our colleague Dr. Kalani had a question about patient-specific interbody implants. You mentioned the titanium that you're using. What do you think of specifically using the software planning to determine the sort of the wedge that you need to be able to get into that interbody space that would be sort of more calculated rather than what we feel in the operating room. We tend to put in these trials, we tend to measure a little bit, we look at the films and we say, okay, this is about the right size, it's the right feel based on our distraction. How about something a little bit more scientific?
Yeah, I don't know if I could comment on the specific interbody implants. I think you can put whatever size you want once you open up the level that you're working on. To be more scientific, again, comes back just to the basics. How much lordosis does that patient need? And you can calculate how much that specific patient would potentially need, at least with our current knowledge base. I know this talk was about how it evolved so much within the last decade or so, really. And once you calculate that, you could use the software and actually with pretty good accuracy, at least at that level, of how much lordosis you need to obtain. And true, a lot of these interbody graphs will say it's hyperlordotic and will give you 20 degrees supposedly, and afterwards you find out that you don't get that 20 degrees. That's why you got to reflect and figure out why we didn't get that. Was it because we didn't release enough posteriorly? We didn't compress? Were we worried about a tethered nerve root that we didn't want to cause any neuroforaminal compression? Should we have approached it from an anterior approach or a lateral approach to be able to really take advantage of that new kind of methodology to be able to get more robust lordosis? These are all things, again, going back to those basics that could be incorporated to kind of maximize your success.
Thanks, appreciate that.
Well, thank you, Dr. Bakhsheshian. Thank you everyone to our audience. We're planning a great year ahead for Grand Rounds. So thank you for attending today, and follow us on Twitter and you'll be receiving an email about upcoming talks. So Dr. Bakhsheshian, thank you again for honoring us with your great talk today. It's very inspiring and getting us all to think about all those great concepts related to how we can better enhance patient care with these new technologies. So thank you so much. Thank you to our audience as well. Have a great day, everyone.
It was an honor. Thank you, guys.
Thank you, sir.